Hello, everyone. My name is Dr. Vishwas Ravishankar. I'll be talking to you today about the overview of imaging in bone tumors. So before that, I'm a graduate from India. So, so the objective of this presentation is to give you all an overview of bone tumors and give you an approach as to how to formulate a differential diagnosis in when you see a suspicious lesion in an X-ray or CT scan, because many bone tumors look alike, and it's important to differentiate which is which and come to a proper differential diagnosis. And we're going to look at how some of the common bone tumors appear in X-rays and CT scan. When it comes to bone tumors, these can vary depending on patient demographics. Some of the tumors are common in younger individuals. For example, osteosarcoma, Ewing sarcoma can be seen in people younger than 30 years of age. Few of the tumors like multiple myeloma and metastatic lesions are typically seen patients above 40 or 50 years of age. And these tumors can also vary depending on the type of bone involved. Some tumors might involve long bones like osteosarcoma, and few tumors such as chondrosarcoma can involve flat bones such as scapula and pelvic bones. Again, location within the bone also comes to play when you are differentiating, when you're diagnosing these tumors. Some tumors are epiphyseal, some tumors are diaphyseal. And also, we are going to look at how these tumors can affect the environment of the bone and the periosteal reaction, and also the matrix formation. So this is the age distribution of some of the common tumors that we encounter routinely. In patients less than 30 years of age, some of the common tumors we see are malignant tumors such as osteosarcoma and Ewing sarcoma, and some of the cystic lesions such as unicameral bone cysts, aneurysmal bone cysts are typically the lesions seen in young patients. As opposed to patients more than 30 years of age, you tend to see malignant lesions such as metastatic disease, and sometimes multiple myeloma and chondrosarcoma diseases of the elderly. And intermediate age group, 20 to 50 years of age, patients can have present with a giant cell tumor and lymphoma. This is kind of a gray zone. So coming to how the matrix looks like. So one of the common concepts that we have to understand while describing radiological features of these tumors as matrix, whether it's producing osteoid matrix, is it producing chondroid or ground glass matrix. So the image on the left, we see that there is an opacification of the ossification of the proximal tibia. It is dense, hyperdense lesion that you see, and this is characteristic osteoid matrix that you see there. This is the osteoid matrix, and when it comes to second image here, this is a chondroid matrix, where you typically see like a ring and arc calcification. So let me just get the pen here. So you see sort of like a ring-like structure here and an arc-like structure here, which gives you like a popcorn calcification appearance. This is typically seen in chondroid lesions. And when it comes to ground-glass opacity, some of the common tumors which present with such appearance are fibrous dysplasia and some of the cystic lesions like aneurysmal bone cyst and unicameral bone cyst. This is a brief overview of classification depending on whether it's osteoid, chondroid, or fibrous or cystic lesions, and whether these are malignant or benign. I'm not going to go into detail of this because we'll be discussing further each one of these and how they appear on images. Another important radiological aspect that we need to know while describing the bone tumors is a periosteal reaction. Naturally, when there is a bone tumor, the soft tissue part of the periosteum tries to contain the bone tumor within the confines of the bone, and you tend to see a periosteal reaction like shown in the images here. These two different type of periosteal reactions are characteristically described as aggressive kind of periosteal reaction, meaning that in the battle between periosteum and battle between the periosteum and the bone tumor, for that matter, the bone tumor has won and it has been successful in invading the soft tissue space. The image on the left is seen as sunburst appearance. It is classically seen in osteosarcoma, where you see like a cloudy opacities coming out from the bone, that is proximal fibula, into the soft tissue space. Another characteristic feature of osteosarcoma is Codman's triangle, as most of you might know. This is a tumor formed by the, this is the lesion formed by the three different parts. One is periosteum, which is trying to contain the bone tumor within the confines of the bone, and the underlying part is the bony surface, and the outgrowing part is the bone tumor. So this is the Codman's triangle that is classically described in osteosarcoma. And another type of lesion, a periosteal reaction, is lamellated periosteal reaction. This is classically described as onion skin appearance. This is seen in case of Ewing sarcoma. Let me just get a pen here. So if you just observe it closely enough, you see there are arcs of ossification, periosteal reaction, and then hyperlucency, and then again formation of bone, and then lucency, and then again bone formation. This is an onion skin appearance that we typically see in Ewing sarcoma. And the previous two periosteal reactions are described as very aggressive. These are characteristically seen in aggressive type of lesions. And this solid periosteal reaction is seen in non-aggressive type of lesion in benign bone tumors. So if anyone is interested in knowing more about periosteal reaction, I would encourage you to go through this article, which describes various kind of periosteal reactions. So let's go over and see how these different osteoid tumors are seen in X-rays and other type of scans such as CT scan and MRIs. We'll be discussing this in case scenarios. The case one, you see a 25-year-old female with incidental finding of a dense lesion on the hip X-ray. So this is the X-ray of the hip. Whenever you see this kind of lesion, your mind immediately goes to think that whether this could be METS. Yes, this could be a prostatic METS, but we also need to consider this could be a benign lesion as well. If you compare these lesions to previous X-rays, if you find these lesions are still present on the previous X-rays, then probably you could think that this is probably a benign lesion. This is a bone island. Bone island is nothing but bone within a bone, which is a lamellar bone within a cortical bone, which is seen in some few patients incidentally. These do not cause any symptoms. And the image on the right, this is an axial image of the bone with a dense hypersclerotic lesion, which is characteristic of bone island. And if you further image these, lesions with an MRI, you tend to see an hypointense lesion on both T1 and T2 images, which are suggestive of bone island. And the way to differentiate between these bone islands and prostatic METS is by, if you have high index of suspicion, you could do nuclear medicine uptake scan, wherein prostatic METS can light up in these kind of scans, whereas bone island remains quiescent. Another variant of the same disease, that is, the bone island, is osteopoikilosis. You kind of see like many ossified spots in and around the joint. These are very benign lesions, and you see these punctate calcifications. This is an autosomal dominant disorder, and when you do an MRI, you kind of see these cystic lesions. Again, this could be differentiated between the metastatic lesions and osteopoikilosis by doing a nuclear medicine bone scan, wherein metastatic lesions can show uptake. I'm sorry, I might have referred this to cystic lesions. These are not cystic lesions. The lesions here appear hypointense on MRI is what I meant to say, sorry. So let's go over and look at how other tumors of osteoid variety in benign kind were present. This is an asymptomatic 20-year-old male who visits a dentist and is found to have multiple mandibular masses. And these are the imaging findings. So these are osteomas. Osteomas are again benign bone tumors arising from the surface of the bone, which are dense sclerotic lesions that you can typically, which you can see here in the laser pointer here on the frontal sinus. These have predilection for developing in the facial bones, especially the mandible and the maxilla, and they could also be seen in arising from the walls of the sinuses. One of the characteristic syndrome which these tumors are associated with is Gardner syndrome, where it's a triad of desmoid tumor, colonic polyps, and multiple osteomas. So it is very important to rule out colonic polyps in patients presenting with such tumors to rule out any colonic polyps or colonic cancer. And these have propensity to undergo malignant transformation. These polyps have propensity to undergo malignant transformation. And if you drill these tumors for biopsy, you almost feel like you're drilling a rock. So that's how hard these are. And these tumors arise from these surface of the bone, especially the facial bones. So coming to case 3, let's look at how a patient with osteoid osteoma present. This is a classic presentation of an osteoid osteoma. Osteoid osteoma is a disease of an adolescent, and you have a 14-year-old male with a thigh pain, which is worse at night, and the pain is relieved by taking non-steroidal anti-inflammatory drugs. This is the classic presentation of osteoid osteoma. And when you image these findings on an X-ray, you see a central area of nidus, which is mineralized due to osteoid mineralization, and a surrounding hyperlucency. These findings are typical of osteoid osteoma. And these tumors tend to arise from the cortical area, and they tend to produce a lot of prostaglandins, due to which you might find a lot of inflammatory reaction if you do MRI scan. And the imaging modality of diagnostic modality of choice is a CT scan, where you again see a central nidus surrounded by hyperlucency, and you also can see here a solid periosteal reaction, which is due to tumor spread arising from the cortex. And this solid periosteal reaction means that it is quite benign in nature. And the reason why patients experience pain relief on taking non-steroidal anti-inflammatory drugs is because these tumors produce a lot of prostaglandin, and hence the NSAIDs can inhibit the production of prostaglandins and achieve pain relief. This is another image from a different patient where incidentally there was a finding of this kind of lesion in the intra-articular place, that is especially in the subtalar joint. You can see that in the T2 weighted image, there is edema of the bone marrow in the talus. That is because of inflammation of the osteoid osteoma. And also you can see that there is effusion of the subtalar joint, again elicited by intense inflammation by osteoid osteomas. Again, these kind of intra-articular osteoid osteomas are rare, but you can still expect to see sometimes incidentally. Osteoblastoma is a kind of osteoid osteoma, but it's typically bigger in size. That's the only difference. Osteoblastoma is a tumor which is more than 2 centimeters in dimension. If it's less than 2 centimeters, it's called osteoid osteoma. These osteoblastomas are more commonly seen in posterior elements of the spine. And those are the only 2 differences between osteoblastoma and osteoma. And in this case, you can see that the tumor is arising from the distal end of the tibia, and you can see that there is a solid periosteal reaction surrounding the tumor. And you can see that in the axial space, it is not invading the soft tissue. So when it comes to bone tumors, bone lesions, producing intense bone marrow edema and MRI, you have to consider these four lesions in differential diagnosis. One is osteoid osteoma or osteoblastoma. Second is chondroblastoma, which is seen in younger individuals and seen in epiphyseal region. And the third lesion is Brody's abscess, which is present in epiphyseal metaphyseal region. And you might see that there might be excessive tenderness and elevated temperature and elevated inflammatory markers. And the other lesion is eosinophilic granuloma. We're going to discuss some of these in the further slides. So just wanted to give you a differential diagnosis as to when you see a lesion with intense bone marrow edema on MRI. So let's also look at how an osteosarcoma might present like. This is an earlier image that we looked at. This is whenever you see this image, your alarm bells start ringing. This is characteristic of a malignant lesion. This is the tumor which is seen in mostly younger patients, less than 30-year-old. This is a conventional osteosarcoma. You can see these cloudy opacities arising from the proximal fibula extending into the soft tissue space, which is characteristically described as sunburst appearance, and also the Cordon's triangle, which is a periaxial reaction to osteosarcoma. And when you do further scan these tumors by an MRI, you kind of tend to understand the severity of these lesions better. You can see that these tumors are spreading into the soft tissue space here, and also the thin gray line that you see that there is a periosteum, and the underlying whitish area on a MRI is a bony tumor. And you can also see that the tumor has invaded and penetrated across the periosteum into the soft tissue space. These are the characteristic typical imaging findings of osteosarcoma, and this is a conventional type. And there are different kinds of other osteosarcomas, which we are going to briefly touch upon in further slides. This is a diagram, an image of another patient. This is a T1 weighted image where you can see, typically you see that the marrow, which is filled with fat, should appear white. But when you see that the marrow is hypointense on a T1 weighted image, much less than the muscle surrounding it, that's a red flag sign. You must further evaluate it by doing some other scans. And you can see the image on the right. This is a fat stat image. You see that the bone periosteum is almost completely stripped off circumferentially. And you see here that the black arrow, it has also crossed the periosteum and is seeping into the posterior space, posterior aspect of the popliteal fossa, almost reaching the posterior popliteal vessels. And if it reaches the popliteal vessels, it might spread into different parts of the body and can metastasize. Before we move further, I also wanted to talk about skip lesions. Some of these tumors, these osteosarcoma, can present with individual isolated sporadic lesions in the other parts of the diaphysis. So it's very important to scan the whole length of the femur or the whole length of the tibia or whichever bone that is involved, so that we don't miss any skip lesions. So that's one thing I wanted to talk about. Another kind of variety of osteosarcoma is the paraosteal osteosarcoma, where these kind of lesions, for some reason, are found only in posterior aspect of the distal femur. One of the good things about these, not good things, I mean, fairly good things about these tumors is that these tumors have a better prognosis than the conventional osteosarcoma. You can see that the cauliflower-like extension of the tumor into the posterior aspect of the thigh, that is paraosteal osteosarcoma. Another kind of osteosarcoma is telangiectatic osteosarcoma. Telangiectasias, whenever you see this kind of fluid image on an MRI scan, you tend to diagnose it as aneurysmal bone cyst. But we also need to keep in mind that this could be telangiectatic osteosarcoma. If you see the image closely here on the left, that is the X-ray image, you can see ossification of the soft tissue surrounding the proximal fibula. This is characteristic of telangiectatic osteosarcoma. When you're combined with the image on the left, and if you see this fluid level on MRI scan, you have to have telangiectatic osteosarcoma as part of your differential diagnosis. Again, this is a different patient who the surgeon thought that it was aneurysmal bone cyst, but in fact, he turned out to be an osteosarcoma because this patient had a fluid level. This tend to mislead the diagnosis. You always need to keep in mind that this could be telangiectatic osteosarcoma. So, as I told earlier, this osteosarcoma can present in elderly individuals as well. This is typically a disease of young, but it can present in older patients, especially patients who are having history of Paget's disease or who have had history of chronic irradiation or chronic osteomyelitis. When you see this kind of picture on such patients, you should immediately have thoughts about secondary osteosarcoma. In this image, you can see that there is cloudy appearance of a distal aspect of femur, sort of irregular margins with infiltration into the soft tissue space. This is secondary osteosarcoma. One of the differentials you can consider, depending on the when you take into account the age of the patient, especially more than 50, is chondrosarcoma. To differentiate between the two, you could do a bone biopsy by a bone oncosurgeon. So one of the other characteristic findings that you see in secondary osteosarcomas are ossified pulmonary nodules. These are typical of secondary osteosarcoma, secondary to Paget's disease. Let's look at some of the presenting features of chondroid lesions, namely benign and malignant. Benign lesions could be osteochondroma, enchondroma, chondroblastoma, and chondrosarcoma. Sorry, the malignant lesion is chondrosarcoma. So case 6, a 7-year-old boy with multiple bony prominences over the distal femur and phalanges of the hand. And whenever you see this image, of a young boy presenting with multiple palpable masses, especially in the distal femur or in the hand, one of the differential diagnoses you can think of is osteochondromas. So osteochondromas are benign bone tumors. They arise from the epiphyseal-metaphyseal region of the long bones, or it could be small bones. They can be either pedunculated, like the one here, where you can see stalk of the lesion, or it could be sessile, where you might not find any pedunculation. And this characteristic trumpeting of distal femur is found in osteochondromas. And this could involve multiple bones, where in fact then it's called multiple hereditary exostosis. These kind of lesions have a typical characteristic appearance of a cartilaginous cap. When you do a T2 weighted image, MRI image, you can see the hyperintense lesion is called as cartilaginous cap. If it's more than 2 centimeter in dimension, then you must evaluate further, because there is increased risk of malignant conversion if there is more than 2 centimeter cartilaginous cap. So another patient, the 7-year-old boy, let's say a 7-year-old boy with an incidental finding of well-circumscribed lesion in the epiphyseal region. This is characteristic of chondroblastomas. You can give multiple differential diagnosis, but the typical findings are well-circumscribed radiolucent lesion or a lytic lesion involving the epiphysis of the bone, with sclerotic margins, with no soft tissue infiltration. These are typical of chondroblastoma. Whenever you see these kind of lytic lesions in the epiphyseal region, you have to consider a few other differential diagnoses, such as Brody's abscess or giant cell tumor, or it could be eosinophilic adenoma. But the way to differentiate between chondroblastoma and Brodys abscess is by MRI and also by clinical signs. If you see that there is a solid lesion instead of a cystic appearance, then the diagnosis points towards chondroblastoma. But it's also important to include Brodys abscess as a differential diagnosis. So this is a case 8, 55-year-old male presenting with an incidental finding of bony lesion on an X-ray like this. Whenever you see this kind of X-ray, which is well circumscribed with a popcorn-like calcification of the cartilaginous matrix or a chondroid matrix, you're quite reassured that this can be a benign lesion. And this is a diagnosis of an enchondroma, which is a benign lesion arising from the cartilaginous matrix. And when you do an MRI scan, you kind of see the lobulated, well circumscribed lesion, which is confined to the epiphyseal-metaphyseal region. And if you see these kind of multiple enchondromas, we have to think of two differential diagnoses. One is syndromic association, which is Ollius disease, and the other is Maffucci syndrome. The difference between these two is that Maffucci syndrome also has an associated hemangioma, and there is an elevated risk of chondrosarcoma. And let's see how the malignant variety of this chondroid matrix tumor can present with, namely the chondrosarcoma. This is a tumor of the elderly. This typically is seen in patients more than 50 years of age, and that typically involve flat bones. I have taken up this X-ray because it was evident in from a radiological journal. So this is a tumor. This is a plain X-ray of the hand, which is, you can see that there is extension of the tumor into the soft tissue space, and also you can see that there is punctate popcorn calcification of the chondroid matrix. And these tumors are tumors are characteristic of chondrosarcoma. This, whenever you see this kind of image, you think that this can be an aggressive lesion, and it would need further workup. And when you do a further MRI, you better appreciate the extent of the lesion. You can see here that the lesion is extended past the bone and is extending into the soft tissues as well. So these imaging findings are characteristic of chondrosarcoma. And these tumors are more commonly seen in flat bones, typically that is scapula and pelvic bones. Some of the other lesions that we can discuss today are fibrous and cystic lesions, namely non-ossifying fibroma, fibrous dysplasia, and some of the cystic lesions such as unicameral bone cyst, aneurysmal bone cyst, and giant cell tumor. So let's say a case 10, a 45-year-old male with an incidental bony lesion presenting like this on an X-ray. You see that this is neither an osteoid matrix, this is neither a chondroid matrix. This is characteristically presenting as the ground glass appearance of the lesion. This is an X-ray of the distal tibia on a lateral view. You can see that the margins are quite well defined, with the well circumscribed sclerotic borders. You don't see any invasion into the soft tissues, and you kind of see that there are internal septations. These are typical of non-ossifying fibroma. And if you do further MRI, you can better appreciate the kind of fibrous lesion, cystic lesion, which present within the substance of the tumor. And these tumors do not invade the soft tissue because of their benign nature. And these do not touch lesions. You do not do any biopsy because they tend to regress as the patient ages. Let's see how a fibrous dysplasia patient can present with. See, this is a image of an elbow lateral view, where you can see that obviously that the bone is quite deformed and it's not looking like a normal bone on an X-ray. You see a ground glass opacities on lateral imaging here on the distal aspect of the humerus and also in radius. These findings are typical of fibrous dysplasia. These lesions can involve either one bone, or then it's called monoostotic fibrous dysplasia. And if it involves more than one bone, it is polyostotic fibrous dysplasia. This is another image of the proximal aspect of the femur along with the hip joint, where you see that the characteristic shepherd crook deformity. These findings are typical of fibrous dysplasia. There is a plastic deformation of the proximal end of the femur as well as the femoral head, and also some ground glass opacities of the shaft of the femur. Whenever you see this fibrous dysplasia, you tend to associate with another syndrome. It is a McCune-Albright syndrome associated with fibrous dysplasia along with cephaloid spots and precocious puberty. That is one syndromic association that we can think of whenever we see this kind of picture. Let's see how unicameral bone cysts look like. So this is a 6-year-old boy presenting with pain in the shoulder and arm. These kind of tumors, cystic lesions rather than tumors, tend to affect the epiphyseal-metaphyseal junction. And as the patients age, they tend to migrate towards the diaphysis. On an X-ray, you can see a radiolucent lesion on the proximal aspect of the femur. And the characteristic imaging feature of these kind of cysts are fallen leaf sign. What it means is that due to pathological fracture of the bone involved, the cortex tends to fall off into the dependent area, and you see this opacified lesion or a bone fragment in this dependent area. This is the fallen leaf sign, which is seen in unicameral bone cyst. And when you do an MRI, you appreciate that this is a well-circumscribed cystic lesion without any contrast enhancement. And you need to differentiate it from aneurysmal bone cyst and giant cell tumor. And whenever you see this kind of lesion, you need to include these in your differential diagnosis. Let's see how an aneurysmal bone cyst look like. So this is a 30-year-old male presented with atraumatic knee pain and swelling. And you see this kind of aneurysmal or expansile bony lytic lesion in the metaphyseal region of the proximal tibia. So you see this is not invading into the soft tissues. And when you further do MRI scan, you see multiple fluid level. These lesions are these multiple fluid levels are characteristic of aneurysmal bone cyst. As I said earlier, when you see this multiple fluid or blood fluid or blood levels, you have to consider telangiectatic osteosarcoma in your differential diagnosis. And you have when you do a contrast enhancement, the periphery of the lesion gets enhanced as well as the internal septations. So this is a characteristic of aneurysmal bone cyst. When it comes to giant cell tumor, these tumors arise in a patient typically aged 20 to 50 years of age. And there are specific characteristic features of these giant cell tumors. Classically in textbooks, you see them described as 4 E's of giant cell tumor. This could be eccentric, expansile with eggshell calcification, and in epiphyseal in location. Whenever you have this kind of lytic lesion in the epiphyseal-metaphyseal junction or epiphyseal region in a skeletally mature patient, you have to have giant cell tumor in your differential diagnosis. These giant cell tumors arise from the osteoclast progenitor cells and produce these characteristic findings on these X-rays. And when you further scan with an MRI, you sort of see these walled appearance on a T1 and T2 images. And these are some of the findings of giant cell tumors. And again, this is another image of giant cell tumor where you see the lesion involving the distal aspect of the radius at the epiphyseal junction. And you can see that it's very eccentric, unlike any other tumor. and it is expansile, and you can see that there might be some few eggshell calcification here and there with internal septations. So this is classic appearance of giant cell tumor. So we have been discussing about these internal tuberculations all the while, and whenever you see these tuberculations on a plain imaging on an X-ray, you need to consider these diagnoses in the back of your mind. So we have a mnemonic for that. So it's called changed. It could be chondromyxoid fibroma. It could be hemangioma of the bone. It could be aneurysmal bone cyst. It could be non-ossifying fibroma. It could be giant cell tumor or a desmoblastic fibroma. So let's review some of the imaging findings of a few of the other miscellaneous tumors and metastasis. So let's look at how Ewing sarcoma can present with. Ewing sarcoma is a tumor that is typically seen in patients younger than 20. Again, it is the normal age group is described as a 15 to 20-year-old. Whenever there is a 15 to 20-year-old patient presenting with thigh pain and having this sort of hazy picture of the proximal diaphyseal aspect of the femur or any long bone, you need to think about Ewing sarcoma. You cannot appreciate better in this X-ray, but if you further image these with MRIs, you tend to understand the gravity of the situation. When you just look at the X-rays here, you might think that this could be fairly benign. There is subtle evidence of periosteal reaction, but when you further do scans with T1 and T2 weighted images, you see that there is hyperintense lesion and there is intense edema involving the bone marrow and extent of the soft tissue penetration in the medial aspect of the femur thigh bone. So again, this kind of tumor affects the diaphysis of the long bone and is typically seen in younger individuals. So another important diagnosis that I'll be discussing today is eosinophilic granuloma. So these lesions are seen in younger individuals, the pediatric patients. It presents with multiple lytic lesions in multiple bones, and it could be, you could say that it is corresponding to a pediatric version of a multiple myeloma, except that this tumor is benign. Whenever you see multiple myeloma, whenever you say multiple myeloma in adults, you kind of see this punched out lesions and also multiple lytic lesions all over the bone. But this is a pediatric version, and this is a benign tumor. When you do MRI scan of these tumors, you see hyper intense lesion finding due to edema, and this is one of the differential diagnoses you need to consider when you are doing whenever you have a bone marrow with edema. So this is the last image that I will be talking about today. This is a tumor of the old 77-year-old presenting with typical crab findings, that is hypercalcemia, anemia, renal failure, and bone pain. You have a differential diagnosis of multiple myeloma in your mind already. So these multiple myelomas present with multiple punched out lesions on the skull. As you can see here on the skull X-rays, and if you further image with of the long bones, like you can see this, there is a pathological fracture of the humerus there, and also you see this, there is multiple lytic lesions on a radial shaft as well as in the ulna bone. You kind of tend to see moth-eaten appearance of these long bone lesions. So these are characteristic findings of multiple myeloma, and whenever you see this, you do a confirmatory serum protein electrophoresis to confirm the diagnosis. These are some of the common bone tumors that I wanted to discuss with you in a brief overview, and these are my bibliography from where I took most of these images. And Dr. Scott Skiffman's presentation was immensely helpful in getting these images. Thank you very much for your kind attention. And I want to thank Chicago Telerad for giving me this opportunity today. Thank you.